Thank you. Good morning. Very happy to be here today, as I'm sure most of you are. So we have a very interesting group and panel for you guys this morning, and I think a great transition from the discussion we all just witnessed. So this panel is called Preparing the Healthcare Workforce for AI in the Industry. My name is Brett Meeks. I'm Vice President of Horizon Government Affairs. We are a all healthcare all the time policy and advocacy shop. So my wife says, you need to quickly tell people what you do. The quick answer is I'm a lobbyist. It is not that simple, but another thing I do is run a coalition called the Health Innovation Alliance, which is very much health tech data. We have large health systems and provider groups. We have patient groups. So across the board, payers, and working with federal government, Congress, and the administration to advance healthcare technology and the use of data. So obviously the last year, a lot of talk about AI. It came up on the last panel, and we'll get into more of that through this discussion. So again, happy to be here. I will say one other thing. It is great to be back on a college campus. It has been a while. Lots of young, enthusiastic, smart people. It is very refreshing, especially this week working in federal affairs. It has been a very intense week, I'll say. So with that, I want to introduce our panelists. Let me pull up my cheat sheet here. So first we have David McSwain, who is the Chief Medical Informatics Officer for UNC Health. We have Sarah Moore, who is the Managing Director of Education for the Digital Medicine Society, or DIME. And then we have Michael Martine, who is the Director of Asset Engineering at IBM, a company some of you may have heard of. So a good mix of, an education-type association, academia and health system, and vendor and technology, and then the random lobbyist on the end, right? So with that, I want to hand it to the panelists, and we'll start with you, David. If you could just sort of give a little bit more of an introduction on yourself, your work, and how it relates to AI.
Sure, yeah, and very happy to be here. And also, I was so excited by the previous panel, that I took a ton of notes and things I may reference back to. So if I pull out my phone, it's not because I'm checking my email. It's because I took notes on what all the awesome things that they were talking about. So I'm the System Chief Medical Informatics Officer for the UNC Health System, and we're 18 hospitals really from across the state, including ambulatory care facilities and thousands of providers. I'm also a pediatric critical care provider. I actually got my start in digital health doing designing virtual care services, starting out with pediatric critical care teleconsultation service for rural emergency departments. So certainly very much in line with what Dr. Meltzer-Brody was talking about as well. And I've evolved into the medical informatics officer role. And obviously, as I've evolved, AI has become increasingly central to a lot of what we do. So, and of course, the other aspect of my work that takes a large chunk of my time is around the electronic health record. I'm the guy in charge of the system that all the physicians are not huge fans of, but I'm not the one person that owns it, unfortunately. But a lot of my job is directed specifically at addressing those issues of burden and burnout and making technological systems work better for our clinicians, our staff, and improve the lives of our patients. And I think there is huge potential for AI to do exactly that. There is also significant potential for it to do the opposite. And we have to approach it in a very thoughtful manner to ensure that we are doing the former.
Perfect. Thank you, David. All right, Sarah, tell us a little bit more about what you do at DIME and what DIME's up to.
Great. Hi, everyone. I'm Sarah Moore. I'm the Managing Director of Education at the Digital Medicine Society. We are a 501c3 nonprofit working at the intersection of healthcare and technology. So we are primarily a convening organization, so bringing folks together from across healthcare systems, technology companies, regulators, payers, to solve the most pressing and persistent challenges in healthcare. As you can imagine, a lot of this has shifted into AI recently, and my team is working on some online coursework focused on AI implementation for healthcare delivery systems.
Perfect. Thank you. Michael, you're last, but not least.
Thank you so much, and good morning, everybody. It's a delight to be back here on the UNC campus. I had the good fortune to attend here for my undergraduate degree, and I always love being here when I have the opportunity. I'm part of the IBM team, as you may have heard before. It's a small company in Research Triangle Park, and I'm part of the 160,000 people organization in IBM Consulting. At IBM Consulting, I lead a team of approximately 700 people globally to deliver on software products that we bring forward via consulting. So it won't be like a standard piece of software you could buy off of IBM's website. It would be more custom kinds of solutions. And for many of those solutions these days, we've been infusing AI in them. IBM's got a huge, long history about leveraging artificial intelligence. Some of you may remember the Jeopardy experience not too long ago. Some of you may remember the Kasparov experience with chess and Deep Blue. So this is not entirely new for us, but the challenges remain, and as it becomes more and more pervasive, elements are around the trustworthy AI and the ethics of AI loom large, and I'm part of the team at IBM, super proud to be a representative in our consulting organization responsible to help make sure that what we deliver adheres to the tenets of responsible AI, and I'm sure those are some things we're going to get into here as well. So looking forward to the conversation. It's been a lot of fun today.
Yeah, thank you. And that was perfect. One thing Michael said I wanted to point out is a lot of talk about AI this year. You can't go to a conference without meeting a lot of AI companies, right? A lot of marketing, and what he said is AI is not really new in a lot of these applications. It has been around, particularly in healthcare. So I wanted to start off the workforce angle of this because all four of us have different points of view on this. And like I said, the last panel really set it up that there's so many challenges, workforce generally, but particularly in healthcare, where there's growing need, there's a huge administrative burden, and burnout, and we've already talked about it just in our intros. So I wanted to put up the sort of broad question. I think it's going to take us a lot of places, but what are the biggest challenges for the healthcare workforce that you guys are seeing, as your team or your customers or your members are actually acquiring, adopting, and implementing, in the field these tools? And Michael, I might start with you.
So thank you very much for that. I want to also start with the notion that my comments are my own comments. They aren't necessarily responsible for the IBM Corporation, so please don't take them as such, and that will give me some freedom to tell you a whole bunch of things. There's not an attorney, and I don't play one on TV. The starting point for this, to me, is in dual spaces around data. And the woman who was sitting in the chair right here, and I did not get a chance to speak with her right afterwards from the keynote, talked quite a bit around the idea of surrounding the individual, the person, to provide the person with the appropriate care that they needed. And I'm not selling IBM technologies and things like that, but I can tell you a couple of stories. And one of them is a capability that IBM created in conjunction with Microsoft and for Sonoma County in California to help surround an individual with the appropriate data, so that if a person came forward, they were a veteran, they're returning to the workforce, they need a variety of services. They may need healthcare services, they may need housing services, they may need a variety of services. Today, that's very, very, very disjointed. And if you've got different divisions in county or state government that are designed to help a person, that individual probably doesn't know how to go about getting all of that help that they need. So the data that is available around a person, if it's shared and if it's done in a responsible way so that these various entities in state and federal, county level government can interact with one another, the improvement of that person's life will be tremendous. So I would go that sort of one direction to riff off of what we just heard. The second, and I'll talk about it briefly now, but I think we'll hit more of it later, is around education. And that was also a theme from our prior panel, too. I am deeply, deeply involved in education. It's where I spend my volunteer time and energy. I am blessed to have benefited from North Carolina and the investment that North Carolina has made in education over the years. I'm a graduate of science and math from Durham. I'm volunteering in Morganton on Monday. And it is a case where how do we get the right education at the right level? So I'm delighted to hear elementary school is kind of a foundational point. How do you learn about responsible AI? How do you leverage AI? How do you use it to augment the human to do the things that humans are really excellent at in conjunction with things that computers and artificial intelligence are excellent at? And I'm sure we're going to have a lot more to say on that subject.
Yeah, and so David, talk a little more about how UNC is deploying these types of tools and what sort of issues you're facing, with your team, to set them up, use them, both your direct team on the Informatics side, but also the frontline healthcare workers.
Yeah, well, we talk about the biggest challenges that our healthcare teams are facing, and a lot of it comes down to information overload and responsibility overload. You think about the amount of scientific knowledge that's been generated since I went to medical school. I won't say how long ago that was. It was here, and the subspecialization that's occurred. The population has only increased. It's outstripped our actual workforce capacity, and what has happened with technology in recent decades is that it puts all of the information at your fingertips, but it doesn't help you use it. And so it becomes an overload. You get very overloaded. Now, I say it doesn't help you use it. We've made a lot of progress in that regard. There has been a massive shift, especially in the last decade, of trying to present actionable data instead of all the data, and present it at the right time in the right format. And I think, Dr. Meltzer-Brody mentioned that Epic started as a billing platform, and that's true. And that's one of the challenges, because the easiest thing for an electronic health record to do early on was to make billing and compliance easier for the billing and compliance people, right? And so it shifted the responsibility for billing and compliance to the frontline workers, because now, rather than writing your note and sending it off to a coder and having them take care of the billing, all of a sudden you have to code it, you have to bill it, right? You have to make sure that your documentation has all the components necessary for that billing. And the reason that Epic is the dominant force in the market is not because it started out as a billing company. It's how it's evolved since then. The reason that Epic has really outperformed other electronic health records is that it has shifted its focus to the usability of information and the support of workflows and the support of the end users. And I'm certainly not trying to be a salesman for Epic here, but I'm explaining why it's dominating the market. Epic has the highest level of personalizability of any other EHR. It is invested the most in end user support and training and advocating for that, and really focusing in on those end users to streamline documentation and streamline all of these things. And that's why it's really become so dominant. That's why so many institutions are switching, which is a massive endeavor, switching your EHR. And so when you look at AI, the great promise of generative AI is that it takes a massive amount of information It ingests it, and it allows you to ask natural language questions and get natural language answers that are very relevant to exactly what you asked. So it is an amazing tool to take this massive amount of information and present it to you in the way that you need it at that moment. And so at UNC, we are very focused on capitalizing on that potential to the benefit of our patients and the benefit of our providers. And we have a very strong focus on ensuring that all of our investments and all of our efforts in this area focus first on our patients and our providers to support them, and not just on the business aspect or any operational issues. And that's really a really key part of it.
That's great. Thank you. And Sarah, want to turn to you now, particularly from the education component, because these, I already said these aren't really new, but they might be new to a lot of folks. And to piggyback off David, providers and patients, well, those are different audiences that require different types of education. Could you talk a little bit about how Dime's approaching this?
Yeah, and I think just to pick up on something that David said about sort of shifting responsibility with EHRs, like when we introduce AI into health systems, that's a big responsibility, right? And we're going to have sort of fragmented solutions being used across a health system. Well, whose responsibility is it to be evaluating those sort of across departments, be monitoring them for safety, efficacy? Whose responsibility is it? Is it by department? Is it a new role? What does that person need to know, whether it is sort of an existing role that has added responsibility, or is it a new role? Like we're seeing chief AI officers, that role didn't exist 10 years ago. So the pace at which this is accelerating, I think we have to think seriously about that shift of responsibility and how fast it's going to happen and what those people need to know to be adequately upskilled. So at Dime, we're thinking a lot about sort of role-based upskilling, right? So what frontline providers need to know to use these tools is different than what, say, folks who are making decisions about tool A versus tool B need to know as far as what solution they're going to buy. Someone on the previous panel maybe asked a question about, it's sort of a crowded market, which I think is true. So whose responsibility is it to evaluate these things? What do they need to ask? What questions do they need to know to have that healthy skepticism to then be able to advocate for their choices, right? Enthusiastically and confidently. And people want to be out ahead of this, right? There's a lot of hype right now. There's a lot of FOMO. And people are moving quickly without maybe taking a step back to say, what do we need to make sure that we know to do our due diligence before we just move forward because everybody else is doing it?
Yeah, that's a great tee up to where I wanted to go next, which is what are these tools and what are they not? And specifically in the workforce context, I've heard two versions of this. It is we want to have the best type of technology and tools so we can recruit the best staff, particularly from like a nursing standpoint. We want to help our teams have more time doing why they signed up to do these jobs, to care and treat patients, not do the documentation. The other side of that is, hey, this tool is going to erase half of my responsibilities as my job on the line. So I'm curious, I'll put it up to whoever wants to volunteer first, but how are you guys hearing about both of these sides of AI as the big promise, or Skynet became self-aware and we all had to go underground, and how are you dealing with it?
So I'll jump in first on this, and it's easy to kind of giggle at those thoughts, and it's reasonable to expect that if 40% of your job is doing things that can be automated or can be done by an AI, there's a natural skepticism and reticence for embracing that. So it has to be done holistically, in my mind, at the person level. And when you're figuring out, like Sarah was talking about, roles based, right? If we identify a role, skilled nursing staff, whatever that might be, and we see that there are a variety of things, like David was just talking about, that they need to know in order to bill correctly, and if they put in the wrong thing, it's going to create downstream problems, that it's going to have a lot of rework. I mean, this is the manufacturing problems that we've had in automobile manufacturing and other things for a long time. The best time to fix things is early in the stage before you get to the end, and you have to disassemble stuff and take it apart and put it back together again. So I would say that there are opportunities that require really good change management skills. And change management skills, if you've had an opportunity to work with any of those professionals in the past, they're awesome. They're fantastic. They're also seen as expedient and like, well, it's nice to have and wish we could do all the change management that we need to do. There's marketing, there's talk, there's the coffee mugs, there's all the things. But if we ignore the person level, we ignore that at our peril, which means the transformation doesn't happen in the way that it can or should. And there's resistance that builds up, whether it's an epic system transformation or something like that. So my quick answer to this question is you got to be very person-centric. You got to meet them where they are. You have to show them the benefit of what's going to happen. And in my own personal experience, when we've done large-scale, enterprise-wide transformation efforts, the best spokespeople for this are not the president, or the leader of the crowd. It's the person who's doing the work, who says, hey, Sarah, it used to take me 45 minutes to do this. Let me show you. This happens now in 30 seconds. That person expands the excitement in a way that's just tremendous. And the challenge is to find them and amplify them.
Yeah, healthcare is a very, very personal service, right? And I've actually, one company I work with, when talking about a product, it's a physician who actually helped design a software tool, uses it in his patient care, and he will actually turn the screen around and show the patient, like, look how much faster this is, and let's ask some questions, just so you know what this tool is I'm using. Anyone else you want to talk about that?
Yeah, I think, Brett, to ask, you asked about sort of both sides of that, right? Like, you hear people talking about this could make my job easier, or could this take my job? I think we need to take both of those things very seriously. I think that right now, yes, this has major ability to make all of our jobs easier in whatever we're doing, right? Whether it's ChatGPT helping us with a draft, or whatever, medical scribe solution is helping folks take clinical notes. But I think that we're going to hit another sort of critical inflection point, right? Like, AI has been around, but why is it that all of a sudden in the past year we're all talking about it, right? It's hit this critical inflection point. We have enough data to make it really, really useful. There are interfaces that are really, really user-friendly. OpenAI thinks that artificial general intelligence, which is going to operate better than humans, will be around in the next 10 years. Now, you can do what you want with that, but it's certainly like a provocative statement that I think when we're thinking about folks that are entering the workforce, coming out of school, or sort of in the prime of their career, like, I think that this is going to shift a lot of things. So that's what I think about right now. And so I think about, how do we prepare a workforce for sort of like skating to where the puck is going to be, right? We can talk about today, we can talk about tomorrow, next week, a year from now. What about 3 years from now, 5 years from now? Folks that are in school right now, what does it look like when they get out into the workforce? I think it could look very different, but I'll leave you with that, David.
Well, I think the important thing to understand, and the approach that we take at UNC Health, is to focus on the human in the loop, and really recognize that there is a vast difference between autonomously functioning AI that touches patients and human in the loop AI that touches patients, and they should be treated very differently, because the thresholds for safety and reliability and accuracy are exponentially higher if there's no human in the loop. And right now, I believe there is no AI that has met those thresholds to be autonomously functioning and facing patients without human involvement. Now, and it's not just the safety issues. When you talk about human in the loop, it serves a variety of purposes. On a very practical level, it helps to train the model, right? You have a human in the loop that is actually confirming and validating the information generated by the AI, then you can not only ensure accuracy, but that data can go back into the model to make the model better. It also contributes to the perception of the human around the AI. I think a really important thing, and this gets to the larger digital health picture, this applies to telehealth as well, is technology should be designed to support, not replace. It should be designed to empower, not disrupt. And disrupt is a very overused term. The most disruptive technology is the technology that supports and empowers the people in the workforce. And so we are trialing, and we are very close to moving forward at a large scale with ambient documentation solutions for our clinicians. And some of the responses that we get from our providers who are piloting this technology literally brings tears to my eyes, because they say things like, "This has renewed my love for family medicine. This makes me excited to come to work again. This allows me to spend time with my newborn child," right? I mean, that is amazing. And that's the kind of thing that we should be supporting. And that's the kind of thing that the technology can do. And I think that is really the way we should be looking at this technology across the board. When we talk about telehealth, you know, Dr. Meltzer-Brody mentioned that the pandemic led to an explosion of telehealth because they started paying for it. I think that's true, but I think the bigger impact of the pandemic on telehealth was that it forced integration of telehealth into existing healthcare practices and structures. It took away the push to have telehealth be this separate, disruptive, siloed way of receiving healthcare, and it made telehealth a part of every established clinician's workflow. And when we talk about paying for it in the future, we should keep that in mind, because that's the reason it's not getting permanent payment parity, is because we're not distinguishing to the policymakers the difference between telehealth that supports established healthcare providers and clinicians and telehealth that is meant to replace them. Because in many cases, the telehealth that's meant to replace them is actually just additive services that they're wanting to drive utilization of, right? So that people can go on their computer and get a prescription for something. And it's very, very different. And so understanding those differences and the underlying impacts of those differences is critical.
Yeah, that's a great point. And your last statement sort of sets up some of the policy things I want to turn to. Selfishly, that's my world, right? But before that, your example of ambient listening, and we have a sophisticated audience, but that is just an AI tool that will listen to the physician-patient encounter and add all of it into the EHR. They're still in development, but they're very promising, and it's exactly the type of tool David was talking about that is in real time relieving that physician, clinician burnout and burden, so that they can spend time with their family. They don't have to go home and spend a bunch of time updating the EHR. So it's really great. And with that, that type of tool still in development, still in implementation. I want to ask about resources, because part of this, either running a health system or selling these products and helping people maintain them, it's sort of constant. There's something, a fellow from the Center for Devices and Radiological Health at FDA that's got a heavy hand in regulating a lot of this technology has been talking about continuous monitoring of these types of algorithms when they are deployed in the field. That's full-time staff. That's very resource intensive. And working with policymakers, does that mean we end up having these tools proliferate naturally in places that can afford that? Or the tech companies are interested in because they have large sets of data, so the Google or the Microsoft guy wants access to their data, so they'll send a team member. Well, that's not going to be the same for, there was talk about the need for behavioral health care on the last panel. There's a huge need in community healthcare workers, right? They need these types of tools, so they're not working in these systems. So I'm curious, that was a big question, a little bit of rambling. Nice to meet you guys. But I'm curious, what are the sort of resource issues that you're seeing? And I think that'll set up our, what's the role of government, where I want to take this.
So the resource issues are huge, and this was mentioned in the last panel as well. Some of the technology is so potentially impactful to both burden and costs that it'll pay for itself, and that's easy to get support for. The ambient documentation solution, that's an example of that. It's one of the things that's so exciting because it is likely to pay for itself many times over. Where it doesn't necessarily, I think that's where the investment needs to be, because and that's where I think public-private partnerships and other forms of partnership can play a big role, because the companies that are developing this technology needs to understand what I talked about earlier, which is having that human-focused, supportive approach wins for them in the end as well. That's what, like I said, that's what Epic did. That's why they're the dominant player in the market. Going back to the telehealth for a second, all of the companies, and I've been doing telehealth since 2009, well before the pandemic, all of the companies whose key business focus was around creating a pathway for healthcare separate from established healthcare providers, for the most part, have failed. A lot of them are out of business. Even the massive companies that have tried to start virtual care programs, Walmart recently shut down that program. Amazon recently shut down the program for the 5th time and are reinventing it again, right? I mean, the list goes on and on. Teladoc, who really drove a lot of the alternative pathway to healthcare siloed approach, really struggling. But companies that are genuinely looking to support and augment our healthcare workforce are the ones that are really taking off. And it's harder. It's a lot harder to do that, because in order to do that, you have to engage people on the front lines. You have to engage clinicians and engage multiple stakeholders and really think through how you're going to develop this and understand the problems. But if you can do that, it will set your company up for much greater success in the future. And I think that's where the potential investment could really come from.
Yeah, but I want to take your question about resourcing, perhaps in a slightly different direction, but part of the reason why I'm involved in this panel is some of the work that my team is working on with your neighbors up the road at Duke, where we are focused on implementation for low and middle resource settings. So federally qualified health centers, smaller health systems, how do we make sure that those folks with less resources don't get left behind? So Duke is sort of doing some technical assistance around this implementation work, and then my team is really working on sort of codifying that into learnings that we can push out broadly. There are 1,600 federally qualified health centers across this country. How do we make sure that the folks that receive care there also benefit from these technologies, right? If you're at UNC, you're getting excellent care, having these technologies in your workflows. What about everybody else? And interestingly, what we're hearing from folks as we're designing these courses with our audience of lower and middle resource settings in mind is that folks at higher resource settings also need this information, right? That when you sort of design for one group, it becomes sort of more broadly applicable. So I don't think it solves the answer to your question around continuous monitoring and the resources that takes, but I think we have to sort of think about resourcing holistically, and what people are able to do to implement this at scale.
I love this conversation on so many levels. I'm going to do one other facet on it, and that's going to kind of go on the build and maintain aspect as well as the data and data privacy aspect. So the kind of work that I've been doing of late around AI ethics, my antenna went way up, and I'm going to be a little vulnerable with you guys and kind of lean into it a little, that if we're doing ambient listening, and I'm the patient, and I'm discussing some very personal medical problems, I don't want that to become part of the corpus of information that the data provider now owns, or that it's ascribed to me, or that I'm personally identifiable, or we can probably imagine all kinds of other terrible situations where data like that would happen. So the good news is that there are ways to safeguard this, and that relies upon education and trust and not just a HIPAA form that said, "Oh, you agreed. We're going to protect your data. Everything's fine. Don't worry about it." There has to be enough there. And the way large language models and generative AI work today, you can absolutely do that, so that the training, you're not providing training data, you're providing real world data that's leveraging the benefit of the massive models that cost enormous amounts of power, electricity, water to create. The conversation we're having right now is not going to be recorded, ingested, codified, and used. So there's an aspect of that I think is really important, because I'll take New York City as a good example. If you are applying for a job in New York City, you can opt out of having AI having anything to do with your job application, right? So that's an option. So I could imagine a situation where Epic would need to have a field that says, I'm opting out of ambient listening, right? Even if it's, trust me, everything's fine, it's been inspected and coded and so on. So that's one facet. The other facet I think is interesting to think about too is the maintain side. We in our IBM Technologies side, we could build whatever you want. We have this fun phrase, a small matter of programming, right? We can build anything. Maintaining it is where life gets really tricky, because you can have a few clever people build something, but then your model is set where it is. And then the machine learning that goes around that model can take that model in lots of interesting different directions based upon how it's trained, how it's being used. And that's without code, right? This is machine learning. So you have to have responsible people maintaining the environment for the future, not just to add a new function or feature, but to recognize where is the model going, and that are the guardrails that were put in place when it was evaluated at the beginning still make sense. And is the model still within that realm, or did it morph or move? So I love this conversation, because it highlights what's the promise. The promise is with ambient listening, you can pick up on something that maybe the physician didn't hear, and it was important, and you can kind of whisper in their ear, hey, ask a little bit more about this. The physician is smarter, the patient feels listened to, all kinds of benefit. But we have to take these other elements into consideration too.
I want to pick up on your comment about the allowing patients to opt out, because I think this is a critical thing, and it's not nearly as straightforward as what folks may think. And there's a lot we can get into we could have a whole nother panel on the equity implications for all of this. But I say sometimes, so transparency and autonomy and all of it is extremely important. But transparency, if improperly applied, is a cop-out. An end-user license agreement is transparency, right? And when you think about how you're going to apply transparency, you have to think about how it's going to impact different populations, marginalized populations, populations that speak a different language, right? If you can provide all that information and give them the opportunity to opt out, that could greatly impact the equity of your healthcare system. And because if what you're creating is a tool that can greatly improve their health, and we know that different cultures have different levels of trust in technology, and if we are giving information about that tool that's not in their language that they speak fluently, what are they going to do? They're going to opt out. Right? So now suddenly, by giving them the option to opt out without the appropriate focus on digital health literacy, and without the appropriate focus on giving them the real information that they need in a manner that they can ingest it and use it, we're worsening the health of a vulnerable population. And so we have to think about that very, very carefully, because and if our focus is always on improving the health of our patients and the lives of our patients, and also the improving the work of our providers, that's the other thing. If you have an opt-out button, suddenly every patient that a provider sees, they may have to approach in a completely different way, because there may be a whole different milieu of different technologies that they've opted into this, but not to this, and they've opted into this, and they've said, yeah, you can do this, but only halfway. And suddenly, the provider has to change the way they approach every single patient based on their particular preferences for technology utilization. And Epic would honestly crash and burn if we had to allow every patient to opt out of every form of AI if they wanted to, because you think about clinical decision support, which is a foundational element and baked into almost everything we do in Epic, is a form of AI. And so if the legislation says, if the policy says patients have to be allowed to opt out of AI, we just have to go back to paper, honestly.
You guys are doing a great job setting me up here. Thank you. So yeah, exactly. So full disclosure, I am a lawyer, and I am a recovering Senate staffer. I worked in the United States Senate for a little over 8 years, and have written some laws that I have witnessed different administrations implement in different ways. And these well-intended, well-meaning, let's give an opt-out, you don't realize that will break the system. And the theme, I guess, in a lot of my work with health technology and privacy, which goes hand in hand, is that healthcare is different, not just to the points of how personal it is and how individualized it has to be, how sensitive this information is. At the same time, you want these models, particularly clinical models. I don't think we're quite there on the technology side, but we're hopeful and it's getting there. You want as much de-identified, robust data to train these models as possible. If you end up having an opt-out and there's limited amount of data to train the model, it will be a biased model, right? Which is another one of these major concerns out there. So again, I'm rambling, I'll get back to this, but the regulation of AI is something very topical. And it has been all year. Sorry to say, from a federal level, it's likely not coming soon. Very similar to comprehensive privacy, not a lot of change, not a lot of agreement. They sort of break down. Despite these election results and full disclosure from my viewpoint, health tech policies that we're talking about, it doesn't really change a lot. Despite what happened Tuesday, everyone wants this stuff to work. Some of the talking points change depending on who's in charge, but I've worked across the W. Bush administration, an Obama administration, a Trump administration, a Biden administration, and it's all pushing the same direction. That's not going to change. So sorry to throw that in there.
But wouldn't you say it's also state level laws like California?
That's what I was going to build up is what are you all most concerned about? Because while the federal government is doing some things, but is it stalemate and passing stuff, the states are not at stalemate. So how are you guys navigating this? As example, California passed a law and then it was vetoed that would have set up this same example. I'm curious how, either directly or you're looking to manage this for next year, because it's not going away.
Yeah, for us, we have to deal with compliance all the time. So we've got specialized compliance for various industries, telecommunications, energy, healthcare, et cetera, that there are very specific laws and rules in place. And from a global perspective, we have to deal with GDPR in Europe. We have to deal with what Singapore is putting in place. It's complicated. And the more complicated it gets, you've got all these if-then statements. Well, if California do these things, if New York do these things. So it's tricky, but in the spirit of transparency, trust, the ability to leverage AI to its fullest, if we don't adhere to A, the laws, and B, the pillars that are critical for responsible AI, none of this is going to work anyway, because people won't contribute, and they shouldn't if they don't feel comfortable, and we shouldn't coerce them to do so.
And I'll just add, I think it's a very true point. Ideally, in an ideal world, there would be preemptive federal legislation that would apply across all states around the use of responsible AI and the ways in which to do that. And one thing that I'm proud of at UNC Health, we're really leading the way in responsible AI implementation in terms of our frameworks and our operationalization of that. But the federal government is likely not going to pass a legislation that does this at any significant scale, and if they do, it won't be preemptive, meaning it won't supersede state law. And state governments are going to pass legislation around this, and that has the potential to be very, very difficult. because the bottom line is this technology is designed, and I mean, it's the data, the transfer of data doesn't pay attention to state boundaries, right? It doesn't have geographic issue, but if companies have to design their platform differently in every state, if providers have to use the data differently in every state, if a provider trains at UNC and then goes to Denver and has to work completely differently, then that's an incredible amount of complication. But actually, so one of the ways that we're hoping to approach this, and we had lunch with our Duke colleagues yesterday, talking about a North Carolina collaborative that would involve multiple stakeholders, including policymakers and multiple health systems and societies, et cetera, with the goal of creating kind of gold standard state legislation. Because, and again, not really supportive of state level legislation. I think it's a bad idea, but the reality of it is that is what's going to happen. And so what we want to do is establish state level legislation that minimizes the burden on health systems, minimizes the burden on providers, minimizes the potential negative equity impacts, and does it in a way that can be duplicated by other states. And then actually have kind of an outreach effort around that to be like, this is what we did. What if, a bunch of other states did this too? And so it would functionally work a little bit more like federal legislation.
Yeah, and just sort of one other point on the legislation regulation piece, one of the things that we're thinking about as we're sort of tracking these various state laws and are unlikely to see federal legislation is like, the pace at which this stuff is advancing, how quickly before those laws are outdated, right? So with any of this stuff, we have to be thinking about durability, whether it's educational resources, legislation, the pace that this is moving, are we needing to update it every year, every 2 years? Like, does it become meaningless if the technology has advanced to a point where the legislation doesn't match what we're actually doing and seeing and want to be able to do? So just another thought there.
I'll just add, the other thing that's really critical when it comes to legislation is definitions. You cannot overstate the importance of definitions. And especially when you get into AI, it's, again, much like telehealth. There's so many different types of technology that falls under this umbrella term of AI. AI is a garbage term. It means so many different things. And if you write legislation or policy that just says, for any use of AI, then it's garbage legislation, because it applies to so many different things that are used in so many different ways that you cannot create meaningful policy that doesn't account for those differences and those different approaches and different technologies. And so establishing definitions, and ideally establishing some standard definitions that are shared across states, is incredibly important. I worked in South Carolina before I came to North Carolina. The definition of telehealth in South Carolina is different than the definition of telehealth in North Carolina, right? The definition in California is different. I mean, and that creates an incredible amount of difficulty in subsequent legislation. One of the big challenges to payment for telehealth right now is the way that CMS defined telehealth or telemedicine 20 years ago. Or remote patient monitoring, another example. There's different definitions of that, and now there's lots of problems with actually paying for it because of the way it was defined. And so definitions sounds boring, but it's one of the most critical aspects of policymaking.
Yeah, no, great point. And I want to check. I think we've got about 10 minutes, so I can open up for questions. I wanted to make one last point about the policy angle, just because I know we have some students in here, and it comes to how you approach Congress and the federal government. Remember this: be careful what you ask for. You might get it. And it may not be what you thought you were going to get. To build on one of David's points, Congress has to pass by the end of, I guess, December 20th is their funding deadline, and they will pass another 2-year extension of telehealth benefits and Medicare. They have to do that because the way telehealth is defined in federal statute comes from the 70s and the practice where someone in a rural area drive to their doctor that doctor's office would call a specialist. That's a telehealth visit. So because the statute lives in that reality, we have to change the statute every year to continue the telehealth benefit. It takes an act of Congress to change the statute. Acts of Congress are hard to come by. So as we approach AI, and Sarah was right on, you can't set in federal statute stone of really adaptive, ever-changing technology. So we have to approach this delicately. So with that, want to open this up to questions. We've covered tons of topics. In our prep, they told me nothing is out of line. Bring up anything you want. Raise your hand. Yeah.
So this is a question for David. With UNC, you had mentioned you've rolled out the DAX ambient program. I've heard from a couple of clinicians that it has been extremely well received. Have you rolled it out in the emergency departments? Because that's a resource-deprived area. And then second question, is it just with clinicians or are nurses able to utilize it as well?
These are excellent and timely questions. So both of the platforms that we're currently piloting have emergency department application in the earlier pilot phase. We will be moving forward with piloting it in the emergency room setting as soon as we have decided on our platform and have that opportunity. If we have it available to us now, but we're not going to do that until we've decided on a platform we're actually going to use. And along the same lines, both of the platforms are offering nursing support, and ultimately we'll be expanding that to other clinicians, other use cases. And I think that's critical. That's one of the reasons why we're really excited about this technology, is because it can benefit, it offers immense benefits now, but I think it's dwarfed by the benefits it could provide in the future if, again, it evolves in the right way with a focus on the personnel, on the people, because it will support nursing workflows, it will support respiratory therapy workflows, physical therapy workflows, everything. It's just a matter of kind of helping it to evolve in the right way.
Thank you all for your wonderful perspectives, by the way, today. My question is kind of to the whole panel, really. I'm curious if the way that the FDA currently essentially regulates medical devices, do you find that it's potentially a hindrance or maybe still the correct guardrail to potentially have for something like AI and generative AI, kind of as we go forward into this new era of medical technologies in general?
Sorry, so it's a really great question. There's not one answer to it. They're struggling. I was actually on a panel last week with someone from FDA. The most active area of FDA and medical devices is in AI is the Medical Device Center, CDRH, which I mentioned earlier. And this panelist from CDRH was basically admitting on stage that they're trying to figure it out. It's very new, and it doesn't fit cleanly into the regulatory pathways they have right now. So they're trying to shoehorn a lot of it into the device pathway that doesn't really fit, in my opinion. But I think it's a broad opinion amongst whatever. The best example is clinical decision support tools. There was a final guidance out last year, I think, that says certain types of tools, thank you, are or are not medical devices and therefore subject to full medical device approval, which is very, very expensive. So it's a very delicate approach. One other thing is parts of the current Department of Health and Human Services have taken for EHR AI tools a function-based approach, which I and my coalition Health Innovation Alliance thinks is wrong, because that means just if you're using an algorithm with a broad definition of what an algorithm is that has AI, then you have to meet these requirements. There's transparency right now, but who knows what gets added later. And traditionally, these types of tools have a risk-based approach, and that's a whole nother topic in a panel But all that to say is FDA is struggling. There is an active conversation of, does FDA or someone else need like a software pathway for medical software that's different? That's also scary for many reasons, but it's going to have to change. Government's going to have to adapt because the world's adapting.
I agree with him.
I was just going to add, I think that FDA is looking to industry a little bit to see sort of what they're going to do. I'll also just plug our free resources through DIME that we have regulatory pathways resources, and we're also sort of adapting these in real time to meet exactly questions like this.
I have a question up here. Terrific session. As to the FDA panels, you're absolutely right. They're not suited to do this work. I'm on one of them. The question I have for you has to do with pace of change. There's a lot in the media about how AI is going to totally rework our world in 3 years. Those of us that have been around for a while remember when the human genome was mapped 21 years ago. We're reaping benefits of that, but it didn't do what many, many people said it would do, which is change everything in the space of 2 years. Are we really going to see this change in healthcare? Obviously, the ambient listening devices are a terrific move forward. How widespread is this going to be? How different will things look, as you alluded to earlier, 3 years, 5 years, where the puck is going to be?
I think there's a diffusion of innovation. There's this diffusion of innovation curve, and it progresses differently for different technology. I think what's really going to drive it, to sound like a broken record, is the impact on the frontline worker. Because they're the ones that, at the end of the day, are the adopters, the users, right? And so that's why you're seeing this ambient listening take off the way it is now. Now, the ambient documentation is not brand new. This didn't spring up 2 years ago. In fact, when I took my first CMIO job in South Carolina back in like 2017, that was around the time this technology was introduced. And I said then, I remember one of the first presentations I gave was, this is extraordinarily promising. It's going to be at least 5 years before we really see it explode, but most likely in somewhere around 5 years from now, we're going to see this really take off. And I don't want to brag, but almost exactly 5 years later is when all of a sudden, right? But I think it really is on a technology by technology basis, and it really is around how does it really support the workforce, to get back to the title of the topic.
Yeah, I was just going to add, we see how much investment there's been in the space, and I think that to be actually able to capitalize on that massive, massive investment, we need a workforce that knows how to use these things, knows how to monitor them, knows how to choose which ones to use that are fit for purpose for actual problems. I also, my own personal opinion, I don't think that this is going to be a linear thing. I think we are going to see really drastic change, but that's just my own opinion, if we're able to have a workforce that can enable that.
Education is critical. The Gartner hype cycle is real. And fit-for-purpose models are going to be really crucial. You're not going to want to ask OpenAI or Llama models things that are going to be impactful for medical purposes. So getting that information into the system in a trustworthy way is going to be crucial.
Thanks. So with that, we are at time. Can I get a round of applause for this rock star panel, please? How about the fantastic moderator?